prosthesis results that we have been longing for. Thank you, Charles.
Thank you, Ricard. We know that the rehabilitation of patients with the high above-the-knee amputations are particularly challenging due to the difficulty or the inability of using standard socket prostheses, and that the development of these transdermal osteointegrated devices has shown to be promising treatments for these patients. And this is the prosthesis. It's called OPRA. It's a transdermal prosthetic system that has been implanted in patients for, I think, over 10 years now. So the purpose of this study was to conduct a prospective clinical outcome study on the patients receiving this OPRA system, to use RSA to monitor the implant stability, and to perform a long-term radiographic evaluation of bone changes around these implants. We had 51 patients with 55 implants, 28 males, 23 females. Average age is 45 years of age with a BMI of 25. As you know, it's a two-stage surgical procedure, staged 6 months apart. The first is to put into the titanium implant, and at that same time, tantalum beads were fixed to the implant as well as the surrounding bone, and this is used in RSA to measure relative displacement between those two segments. The second stage is implantation of the transdermal abutment. The plain and RSA radiographs were planned at 6 months after the second stage, 1, 2, 5, 7, and 10 years. This is just an illustration of the two stages. First, the implant is here. You can see the tantalum beads that Ricard has implanted into the surrounding bone. There's also some that are actually attached to the implant, and that's used in the RSA examination. And then, of course, there's some trimming and treatment of the soft tissue for the external prosthesis part. This is the RSA. We used RSA software to measure relative displacements between the implant and the bone. You can see that all the beads are marked in the implant and the surrounding bone, as well as in the calibration cage. These are two simultaneous X-rays that take a stereo radiographic image, and then you can do 3D calculations of relative displacements. On the plain radiographic protocol, the radiographs were graded in 5 categories. Distal bone resorption, that was defined as resorption of the distal bone that caused exposure of the femoral fixture outside of the bone canal. Near bone resorption, or more commonly called radiolucent zones around the implants, and those were defined as being wider than the fixture thread depth. Cortical thinning is a decrease in the width of the cortex, essentially subperiosteal bone resorption along the area of the bone where the fixture was implanted. Cancellization is an increased porosity of the cortex surrounding the fixture. And trabecular streaming or buttressing, that's evidence of hypertrophy on the proximal portion of the implant formed at an angle between the inner cortex and the implant. So each X-ray was graded and compared against the X-ray of the first surgical procedure. And it was graded in each of the zones. The AP X-ray was used and was divided into 6 zones here, and then the 2 distal zones. The same with on the medial lateral view, 6 zones and the 2 distal zones. Want to emphasize that the grading of the radiographs was a qualitative grading of the incidence of occurrence of each of these features in each of the zones. It's not a quantitative measure of the severity of the bone remodeling. So when I show you the percentages, it's a % of the incidence of occurrence of those features. On the results, you can see the RSA results here. The median migration of the implant inside the femoral canal. You can see that they are very low. essentially that's 10 microns here. This is all over time less than really the detection limit even of RSA, which is about 50 microns. You can see the maximum and minimum displacements. Even the maximum displacements are well within tolerable ranges. It has been shown in other studies of 0.1 millimeters, about 100 microns, up to about 200 microns, or 0.2 millimeters of displacements here, as you can see here. We can see, just to touch on this, you'll see this throughout the slides. We have different number of patients followed at different time periods, and most patients are at 1 and 2 years, and these patients obviously are coming up to their 7 and 10 year. So really we only have 3 patients in this RSA study out to 10 years. So another depiction of the displacement of the implants, showing that there's no progressive migration of any of these implants, and they all very stable up to, really, with the numbers that we have, we can comment on up to 7 years stability, although the 2 patients at 10 years also had very stable implants. We look at walking through the radiographic analysis. We first start with a near bone resorption, and that is an example here. This is stage 1, and then this is development of this radiolucent zone or near bone resorption at 2 years on this implant. And if we walk through, there'll be a series of these type of figures that I'll show as the zeros change from 0 to increased incidence. They'll be red just so you can see them, and I'll just walk through them kind of quickly. So this is near bone resorption at stage 2, 0 obviously, and then it takes some time for this to develop. You can see a very small, 2 patients had near bone resorption at 1 year, an additional patient or 2 at 2 years. Again, primarily on the posterior aspect of the implant at the distal region, zone 10 and 11. You see now we have 50 patients there. When we go to 5 years, it drops to 18. So those, of all these 18 patients at 5 years, none had near bone resorption, and at 7 years, also none. And you see, again, only 2 patients at 10 years. And I won't comment further on the 10-year patients because there's so few at this time. Looking at cortical thinning, in this example of cortical thinning, stage 1, you can see the cortex, and then we're comparing all of our examinations. And so this is the worst case or worst example of cortical thinning. Immediately after stage 2, you can see that we already have some cortical thinning occurring in these zones. At 6 months, a higher incidence, especially in these distal regions. At 1 year, we're getting up to 31% on the anterior, zone 9. Again, these are just incidents of cortical thinning. 2 years, 5 years, 33% of these 18 patients. And at 7 years, looking at cancellization, increased porosity of the cortex. As you can see here, cortex at stage 1, and then not thinning, but just increased porosity of that cortex. Again, we see that even has started before or at the time of the X-ray after second stage operation. Again, these incidences are small. These are 2% or so, but you can see that they progress in the zone over a number of zones over time. Still primarily associated with the more distal regions, as you would expect with the bone remodeling. These are very similar to what you would see even around cemented or cementless femoral stems on total hip replacements. Again, at 2 years, up to about 30% of the patients showing some cancellization in all zones. And at 5 years of those 18 patients, and 7 years. Looking at trabecular streaming, the hypertrophy, you can see that develops from the loading of the implant into this bone and hypertrophy of the proximal bone. Again, nothing at stage 2 or 6 months. It takes a little time for this to develop. You can see, again, small incidence of buttressing at 1 year. At 2 years, a little bit of an increase in number of patients. By 5 years, we see 33% of these 18 patients showing signs of buttressing on both sides, or on all 4 sides, really, of the proximal implant. And at 7 years with these 14 patients, those are the numbers. So as far as distal resorption, the actual exposure of the implant out of the canal, there's no instances in these patients that showed resorption of the bone that exposed the distal end of the prosthesis. We can also look at this as an overall percentage, any incidence of a patient demonstrating each of these features in any zone. We can see that the overall percentage of patients with any incidence demonstrated an increase from 6 months to 5 years, with the largest increase in the incidence of these occurrences happening between stage 2 and 6 months. At 2 years, 22% of the patients showed trabecular streaming in 1 or more zones, which increased to 50% by 5 years. Cortical thinning occurred in 1 or more zones in 55% of the patients by 5 years. And patients having cancellation in 1 or more zones decreased from 64% at 2 years to 55% at 5 years. This could either be a reflection of restoration of some of the bone stock due to activity, and it also could be some of the imprecision based on the really not having complete control of the rotation of the femurs in the radiographs. So in conclusion, the current RSA analysis of the OPRA system showed no significant migration or rotation of the osseointegrated implant, and confirming a rigid fixation of these implants, certainly at 7 years, but even the 2 patients at 10 years had stable implants. Cortical remodeling around a load-bearing intermedullary prosthesis is expected. It's a significant remodeling can be seen on the radiographs, occurred in different zones in different patients. We still are remaining to do a correlation of these cortical remodeling processes with patient activity, BMI, implant size, time in situ, length of the remaining femur, I think would be a very interesting correlation to make. And there's others, demographic correlations that are remaining to be performed. There have been no reported failures due to this bone remodeling around these implants. Certainly more plain radiographic follow-up is needed to analyze and assess the long-term severity of this bone loss. The OPRA system is a surgical technique that has been perfected over the last 10 years as a promising new approach for addressing prosthetic challenges faced by these patients with above-the-knee amputations. Thank you.
Thank you very much. The X-ray evaluation is one thing, and the real evaluation of the patients is another important matter that Kerstin Hagberg will talk about, namely prosthetic use and mobility with